So I trained in Toronto in Canada and moved here for my first job up in Whangarei, and I was there about 1 week. I was on call at night and I broke the law without any idea that I had done so. So it was the middle of the night. A woman came in at 21 weeks pregnant. She had just broken her water. She was quickly in front of my eyes becoming septic, and the medical management there is to induce labor with IV oxytocin. Proceeded to do that. She gave birth. She was completely fine. I got called into my boss's office in the morning to tell me that I had broken the law of New Zealand around how I had just provided an abortion. So in Canada, there is no abortion law. It's health. So this was really awful for me personally. He quickly helped me do the paperwork in retrospect and explained the law at the time. So for this talk, I thought I would just take you through the new Abortion Legislation Act from 2020 and the impact of both that and COVID and what we see today 2.5 years later. So if you recall, the first election platform for the Labour Party in 2017, Jacinda Ardern did campaign on abortion law reform. And there was advocacy from across the sector. So Alran's is the most famous, or famous in New Zealand, but certainly it was coming from all areas of the country and all different types of groups. And finally, government passed new legislation on the 24th of March, and it was, you'll know the date because the next day was when we went into level 4 lockdown. For better or for worse, it sort of went a bit under the radar, but it also meant that all of the previous abortion care in this country was done under the Ministry of Justice, and overnight it became Ministry of Health. But overnight, the Ministry of Health was then 100% focused on the COVID response and not really, I mean, there's a different team responsible for abortion care, but it really wasn't looked at with as much attention as we would have wanted. So this is the act, and I've put it up just as a screenshot because you can see that the one line there, sections 10 to 46 replaced with one sentence. So for the under 20 week, which is the vast majority, like 99% of abortions in this country, it just says a qualified health practitioner may provide abortion services to a woman who is not more than 20 weeks pregnant. So suddenly you've lost all the legalese, and it's simply that a qualified health practitioner can provide. There's absolutely no other legal requirements. So that's what led to a huge change in practice, and subsequently with the lockdown, it led to further changes in practice almost immediately. The other thing I'll point out is that it says qualified health practitioner. It no longer says a specialist in obstetrics and gynecology or a GP who has a special interest in gynecology care. So that means we've started a lot of training and education with midwives, nurses, nurse practitioners, GPs, O&G specialists, sexual health physicians. So from a woman's perspective, she can now self-refer. So that's the first thing. She's going to find out she's pregnant. She's going to Google what to do, and she's going to get as much information as she can about what happens next, and then she can refer herself to a provider. So how do you find providers? This is the website that we run, we being APGANS, which is the abortion provider group for Aotearoa, New Zealand, and we're about 180 health practitioners, multidisciplinary, representing all the services in the country. So we keep up this site on a monthly basis, and it gives out lots of information on how to find a provider. And then the Ministry of Health put up this website, which is another, so if you just literally Google abortion New Zealand, you'll get one of these two sites. So they're both very good. It will explain in lay terminology about options for pregnancy and where to get an abortion. So the self-referral is really important. It used to say you had to be referred by your own doctor, which required a woman to have her own doctor. We worked around that a little bit within some of the services, but now she literally just picks up the phone and calls her local provider or calls the 0800 number, Decide, which is also new this year. I'll just put out there that if a woman does come to you, we still do accept referrals from GPs and from walk-in centers and student health services. And it's really nice because you get a bit more context about the background of the patient. But we've probably seen self-referral go from 0 to probably 3/4 of our referrals at the moment. So it's also put a lot of pressure on us as a service to improve. So we used to just accept that the GPs did everything, and we wouldn't even accept the referral until all of those boxes were ticked. But we've really had to look inwards, and the quality improvement I've seen with this change has been huge. So we've gone from a very protracted process to now they self-refer. We get the phone call, we book them in the next day, they get assessed, they get it's just so much quicker. So then you come in and meet your health practitioner, and as I said, it can be any of those specialties, which means that a lot of you might not consider yourselves a health practitioner, because in the past you had to seek out becoming a certifying consultant and register yourself with the Ministry of Justice, and they kept a list, and it was publicly available, and there was a lot of people who didn't want to provide. But I think now that it's so much broader and it's legal, that you can consider it in your own personal practice as a GP, because we know that 1 in 4 women in New Zealand will have an abortion in their lifetime. So you're seeing these people obviously looking for care or have had this care, and I think it's worth all of us learning more about it. I'm teaching it at the med school. I teach it to all my house officers. We're working on getting it into registrar training in ONG at least. And then finally, it's not about coming in front of a committee who has to decide that you have a mental health condition in order to say, yes, I approve that you can have an abortion. Now it's just, it's the same as getting a contraceptive. It's the same as getting a blood pressure medication. It's shared decision making. You all do that really well. And now we get to do this for abortion care, which is amazing. A note about counseling. I'll just actually say one more thing about that, about the health practitioners. So some of you might have a conscientious objection to providing abortion care, and you're totally protected within the law to hold that belief in yourself. But the law now says that you must inform the woman of your views as soon as possible, and you need to also refer the person to the closest provider. So that's new and protected in the law. So if you don't provide, you at least have to know who does, who's near you or near the patient, and make that referral, which is new. Okay, so counseling. Counseling has never been mandatory in the law. What it does say now is that you have to advise the woman of the availability of counseling, and she does not have to attend. She just has to be offered. So that's one of the things that the Ministry of Health has really taken on board, because we at an established abortion service within a hospital setting already have all the counseling and social work set up from before. But if you wanted to open up your own rooms to provide abortion care, you're like, well, I don't have a social worker on staff or a counselor on staff, and to refer into the hospital setting, it's crazy. So the ministry has worked on that, and they finally have provided that nationally, publicly funded this year, and I'll get to that in a moment. So the other change that happened between the Ministry of Justice and the Ministry of Health is we finally were able to get really good data sitting within the health department. So if you go to the Ministry of Health website, there's a few documents. One is the annual report. So you get publicly available information about every abortion that's been done in the country. Every single one is notified. Again, it's legislated that we notify each abortion to the ministry, and there's a whole bunch of legislation around the data that's collected. And then they report it back to us. So this is an example of one of the slides, of one of the diagrams, I should say. So it looks at how many abortions by age group. I've just picked this one out for interest. And it just shows that in the gray line is 20 to 24-year-olds, and the orange line is the 15 to 19-year-olds. So those numbers have been coming down quite a bit. And I like to ask my med students and junior doctors why they think that might be. Any ideas why the abortion rate is going down in the under 24s? So everyone always says LARC, and I'm sure that is a huge contributor, and you're all putting them in, and it's fabulous, and Marina was funded, and Jadelle is now available in New Zealand, all amazing. But Jonathan Haidt, who's a sociologist out of the States, came to New Zealand before the lockdown, and he talked about the influence of social media and how now all the teenagers are sitting on their phones and they're not actually in person and they're just not having sex. So, new research to be done. The huge impact that we've seen from the legislation change is that uptick in the blue line, which is early medical abortion. So EMA, we're trying to go away from the terminology of TOP and to abortion. And the EMAs, the early medicals, have gone up hugely. They're now about 50-50 in our service. And the reason for that, again, is because if people are self-referring, you take out that week or two delay of getting to their own doctor to refer in. Our services have improved significantly because of the lockdowns. We're doing a lot of telehealth. They're able to just get in quicker, and then they have the opportunity to have a medical abortion. It's such a tragedy to me, all the people that I used to see who came in at 9, 10, 11 weeks, and you could see that their scans were done at like 6, 7, 8 weeks, and they could have had a medical, and they just couldn't. So now we're seeing a huge amount of medicals. However, this next graph, sorry, I did the age, oh, sorry, I went backwards. This graph I did, it's not in there, but I think this is hugely important. What happens with the surgicals is you can put an IUD or a Mirena in at the time. With the medicals, you can't. So we've sort of been having to play catch up because we've seen a huge decrease in this, and we are now recognizing this. It took a year to get that data out, and now we know that we need to really up our game in providing LARC. So we can say, go back to your GP. Some of the GPs might not know the woman's had an abortion, so it might be a little awkward. Family planning, I understand there's a 3-month wait in some parts of the country. So each of the abortion services has tried to work really hard with planning and funding within our DHBs to create community-based, publicly funded care the way is provided. I think Bay of Plenty is amazing. I think County's amazing. We've just come to the table at ADHB about, I don't know, maybe 6 months ago. So we're getting there, but that's like a huge issue going forwards that we're really advocating for with the ministry. I had the opportunity to work on the first ever abortion clinical guideline. When it sits in justice, it's all about the law and standards and policies. And now that it sits in health, it's all about evidence-based healthcare and guidelines and practice. So I wrote this guideline alongside 2 other people. We were the 3 medical experts, and then we had a whole steering group that contributed, and then the ministry ratified this last year. So if you look up abortion guideline, it will come up, and it's not too detailed. So we had to really look at the bigger picture and try to really just look at what was actually training. So if you actually want to provide, you actually need a lot more than just the guideline, but we really wanted to set out a standard practice for the whole country to ensure quality and evidence-based. So it's evidence-based practice. So I just put in one slide on EMA because that's this audience. More of you probably would consider doing an EMA than anything surgical. And although amazing GPs provide surgical up to 20 weeks in this country, so it's not to say it that way, but just as a generalization. The most common protocol around the world is you take a 200 milligram mifepristone tablet, and that's followed 24 to 48 hours later by 800 micrograms of misoprostol, and it can be given various ways. And we find it's fairly well tolerated, and it's 95 to 99% successful, but 1% of people will have an ongoing pregnancy. And so part of our assessment of whether someone's eligible for medical abortion is not only like medical criteria for eligibility, it's also, do they have a telephone? Can we text them? Can we get them back in to do that blood test a week later, or a urine test to make sure that the pregnancy hormone levels are falling and the urine test is negative? Otherwise they might, once a year at our service anyway, once a year we have someone come back at 4 or 5 months, and they're feeling quickening and the baby's moving, and then we send them off to you guys and they get a scan, and they unfortunately are pregnant. Of course, they've been exposed now to the misoprostol and the risk of Mobius syndrome, et cetera, et cetera. So we just have to really make sure. We still have a huge loss to follow-up rate of 10 or 15% of people, but we emphasize how important the follow-up is for that reason. So I guess the question next would be, well, could I offer this starting tomorrow? Like literally on Tuesday, could I actually just offer this? So some of the things are definitely in place already. The framework is all there, both legislatively and other. So for example, through APGANS and through the College of Sexual and Reproductive Health, there's lots of education, there's lots of training. I just came from Wellington yesterday. We had a full day on later abortion provision. In terms of safe areas, so that came out about 6 months ago. It was left off the original 2020 legislation for a bit of kerfuffle in the House, but now it's there. They've just developed an application process to get 150 meters around the perimeter of the whole building in which an abortion is provided. So if you think of a hospital like Auckland or Middlemore, if you think about a huge perimeter, that's a huge thing that we've just achieved. You know more about PSO than I do, but now these medications are on PSO, so you have easy access to them. What else do we have available already? So Decide offers virtual counseling, so that's really important. And they also offer information and support. Both before and after. So women can call up and just say, hey, I'm thinking about getting abortion, and they'll go through a pregnancy options discussion. They might say, yeah, I'm definitely having an abortion. I'm 8 weeks, I can't decide between medical and surgical. They can help with those decisions as well. Afterwards, they can, I'm bleeding a lot, I'm not really sure, blah, blah, blah. So they can chat with, it's kind of like a telehealth thing. And it's nationwide and it's publicly funded. And I can tell you that yesterday the Americans at the talk were very jealous. We also do really well on contraception, and I talked about notification already. So everything is in place except funding. So if you think about Section 88, I already know from my GP colleagues how little you get for any early pregnancy visit, and Section 88 is really not intended for this, but we've been told that that is one option, but it's like, I don't know, $50, $70, something really not nearly enough. This could take an hour, it could take 2 visits. So we've made it very clear to the ministry that this is just not enough, not on, and they really need to. So we've been meeting with them every month for literally 2 years trying to get this over the line, and we're trying to work with the College of GPs because really that's such a huge barrier at the moment. The 0800 Decide will be providing EMA by telehealth starting in November, so anyone anywhere can ring up and get the medications and the counseling and the information and the follow-up. But we all know that women also like to see their own practitioner. So it's a great option, but we don't want it to be the only option. So what are our future challenges? That is absolutely number one, not just the EMA funding, but also contraception funding. So yes, the Marine is funded, great, they don't have to pay for the device, but they're still paying for the insertion and your time and the counseling and all the extra stuff that goes around something like that. So that just needs to be, in our view, if you're going national to Fatu Ora, healthcare system reform, this funding has to follow the woman in her entire journey. And the most amazing thing is what happened with the amendment of the PIORA Act a few months ago with development of the Women's Health Strategy. So now there's a whole bunch of really amazing people, and do join in the fight. We're really trying to get a full women's health journey through the healthcare system, which should include all of this that we're talking about. Second trimester surgical, this was what the course was on yesterday, a map of current providers of second try surgical procedures. Currently there's about 6 of us in the country that provide that service, and within 5 years from retirements and whatever, we're probably going to have 2 in the whole country with no pipeline. So we don't learn it in GP training. We don't learn it in O&G training. It's totally off to the side, and you have to come in on your own time and find somebody to train you. There's just no pipeline. So it's a real problem. And I won't even talk about over 20 weeks, but that's a whole other talk about the difficulty in getting people abortions over 20 weeks who just find out really late and have really difficult lives. So this is where we're going, the 0800 Decide number from November, the Pi-Ora bill with the Women's Health Strategy, and just a final note on research. There's lots of research going on at the moment through both Otago, Victoria, and Auckland, and if anyone's interested in helping with any research projects, we're doing trials, we're doing cohort studies of before and after abortion law reform. We're surveying women for some qualitative stuff focusing on Māori and Pacifica and rangatahi. So lots going on in that space. And thank you for having me.